everyone. Can we start the lecture? Can you hear me?
Yes, madam, we can hear you.
Right. Okay. So, do you think there'll be, there aren't any other activities going on, right? This must be the number that is going to join, right? Right. So when it comes to critical care, you tend to think that it's about medicine, medical things, and surgical things or obstetric things, because you tend to sort of associate it with severe illnesses and complications of whatever is going on with our physical health. And that is actually, it is the case, but as we go on, move above the ladder towards the top, now we want to give comprehensive care to our patients. So therefore, now we know that physical health is there, but mental health is also very, very important. And now we are integrating psychiatry and mental health also when it comes to critical care. So let's see what are the psychiatric aspects of critical care. So these are the lesson learning outcomes. Because you have a mental health and psychiatry module coming up, and because you might not understand some of the complicated conditions that I'm talking about, I have kind of decided to just introduce you to the concepts, but not focus too much about management and things into this lecture. But at any point, if you're not clear about something, you can stop me and ask, or you can send a message on the chat box, right? So, critical care, these units are very fast-paced and stressful, and patients heal. Yes, that's the positive aspect of it, but then some suffer and some die. And so therefore, if a particular patient in critical care is really critical, not that patient is suffering. And also, the next patient who witnesses it might suffer. And the staff members suffer. And going beyond that, families suffer. And sometimes, if it is a really, really critical thing, it might go on papers. And what has happened in that particular situation to that patient at critical care might have an impact on people who are living in the whole of the country, right? So it's that important. And in that sense, more than physical care, psychiatric aspects become more important when you talk about the distress and the impact of things. Because when you hear about something that has happened to a critically ill patient, it's not your physical health that is going to be affected, but it's the psychiatric aspects. It's the mental health. So it is a very challenging place for the medical personnel as well. And there's high degree of professional burnout and also post-traumatic stress disorder. Post-traumatic stress disorder is a group of symptoms that cause an impairment to a person following a really, really huge stressor. Like it could be a bomb, it could be floods, it could be a rape, or if like somebody who is really young, dying following a stroke or something, that might have an impact on the doctor who is looking after. And particularly in the ICU, most of the time it's one-to-one care. So you are given a certain patient to look after. So they might have an impact. And therefore, the issues that come up are complex and diverse, and there are neuropsychiatric issues as well as ethical issues. Neuropsychiatric, in the sense, now let's say, what I mean by neuropsychiatric is that, let's say, a person is having a stroke and then that person is confused and the patient is disturbed because of the confusion, then it's a neuropsychiatric manifestation, because the confusion and the fact that the person is irritable and is aggressive is not because of a psychiatric disease. It's because of a delirium, which is directly related to the sepsis or the diabetic ketoacidosis that is going on in that patient. So, in critical care, there is the patient, there is the family, and there is the staff. So, it could be that this patient is the only person who is having an illness, like in the case of encephalitis or something, where the family is suffering because their loved one is ill. But in certain instances, it could be that this patient is the survivor, and somebody who traveled in the same car has died. Or now just recently we saw a patient, a mother in the ICU, and the husband and the child has died. Apart from the fact that this person is being very sick with multiple fractures, do we break the news that the husband and the child has died? This happened a lot in the Easter disasters, like, where one person was left and, like, this person was also paralyzed and there was nobody to go home to. And there is the staff, because it might be like one might expect the staff members to get used to what's going on, and death might become a part of your everyday life, but still, you're affected sometimes. And it's not only about the impact of a dying or a dead patient, but also the responsibility, the stress, because now there are less intensivists, and also there are the issues of staffing problems. So apart from the stressful work, the patient's condition making you stressed, the rosters, the night shifts, those also will stress you out and lead you to burnout. So in critical care, humans suffer from all these issues, and the patient suffers as well. But sometimes, perhaps the patient is unconscious with a GCS of 3, and the others suffer more than the patient. Right. So usually we tend to relate the patient with physical issues, but look, psychological issues. The patient might end up getting depressed because all he can hear is beeps, alarms. There could be social issues, let's say multiple fractures and compartment syndrome, and the patient is in the ICU and you can't go to work. And if this person's leg has got amputated, how is he going to earn after going back? He might be the breadwinner of the family. Then the legal issues. If a person is confused, and can that person give consent to all the interventions that are being carried out? Or is there another way that you could look into? Like, if a person is having a GCS3 where you can't give consent, does the consent of the family is valid? And then ethical issues, confidentiality, and what about respecting autonomy of the patient? Because we ventilate some unconscious patients, and then have we got the permission from the patient? No. So there is no patient involvement there. So ethical issues also come up. So suffering will lead to psychiatric sequelae, and not only the organic etiology leading to psychiatric sequelae, like in the case of having diabetic ketoacidosis and then ending up with delirium and so on, or the patient is now depressed because of the disseminated cancer. patients may already have pre-existing psychiatric issues, like a patient with depression now developing sepsis. And also, like in the cases of, let's say, epilepsy, or it could be something like autoimmune encephalitis, there are neuropsychiatric manifestations. Now, the patients might be like, acting very manic, disinhibited, overactive, irritable because of a space occupied lesion in the brain. And that might be the reason that the patient is in the ICU following surgical removal of the tumor. So, because of the critical illness and its suffering, there could be depression, anxiety coming as clinical entities. And because of the severity of the physical illness, you could end up getting delirium, as I mentioned earlier. And then there could be predisposing factors. Now, let's say an elderly woman who is having diabetes might be having dementia as well. And if this person gets a stroke, the chances of that person getting another delirium or dementia getting worse and getting confused are more. So dementia, that's a predisposing factor. Or substance use. Because let's say somebody who was met with an accident under the influence of alcohol, now with multiple fractures and a subdural hemorrhage, is in the ICU, and the patient would go on to alcohol withdrawal. And if a person is having psychiatric condition, then there is neuroleptic malignant syndrome, which is directly related to antipsychotics that the patients are on. There could be serotonin syndrome. Serotonin syndrome is where there is a high level of serotonin, and the antidepressants, what they do is increase the level of serotonin. And to a patient who's on antidepressants, to cure the pain, if you give tramadol, because tramadol also increases serotonin, there could be serotonin syndrome. Then attempted suicide, deliberate self-harm. That is really directed, like, sometimes we see patients being ventilated because of attempted hanging. Now, this is a failed suicide. So that is because of the underlying psychiatric illness. Then psychoactive substance-related issues, behavioral disturbances. So those are related to psychiatric conditions. Now, let's say a person is having a disseminated cancer and having schizophrenia as well, and there would be behavioral disturbances. So those are the places where psychiatric aspects would come into display. So when you're dealing with patients with psychiatric issues, there is the doctor-patient relationship. Now, manic patients, they have a tendency to get disinhibited. They might fall for the doctor. So doctor-patient relationship. And then patients might, like, let's say, if they divulge any information like about a extramarital relationship or something like that, which the doctor needs to know, we need to safeguard confidentiality. And consent, that's an issue, because a person who is having schizophrenia, and that person might not be able to give valid consent. For example, in schizophrenia, I might develop the firm abnormal belief that the doctors are going to kill me. So therefore, I might not give consent to amputate my leg, despite the fact that my toe is getting gangrenous. So there, the consent or not giving consent is not valid, because it's driven by that abnormal belief, the delusion. Then sometimes, if a patient is not having the capacity to give consent, but you know that this patient is dying, then we can go ahead and give treatment by using the best interest principle. So you are doing to safeguard the life of the patient. But that cannot be applied to instances where it's not life-threatening. And then what about research? Because if they can't give consent to an intervention, how can they give consent to participate in a research? But then research is the thing that drives development of new knowledge. We can't do it without research as well. So those are the issues that might come up specifically in the critical setting in patients with psychiatric illnesses. So something which is important, capacity. So the patient will need to have a clear and full understanding of the nature of the condition to be treated. Now, let's say if it is amputation of the leg, the person should know what this is, what the problem is, and why a particular intervention is being carried out, what are the pros and cons, and the possible side effects. They should have it. And then the patient should agree freely to undergo the amputation. So be competent to. So the patient should be able to weigh the risks and benefits of this intervention. So that's called competent to take decisions. So now let's say a patient who is in the critical care because of the condition, let's say a delirium where the patient is confused. Because of the condition, now the patient does not have the capacity to give consent because the person can't think straight. Or on the other hand, like I said earlier, the patient might not give consent because of the psychiatric issue, like schizophrenia. Because patient is not giving consent because let's say I'm the patient, I don't give consent because I think that the doctors are there to kill me, and that's why they're going to amputate my leg. So I mentioned freely, they should be able to give freely. So apart from the psychiatric illness, is there somebody telling something? Is the patient giving this consent in an autonomous manner? Or is that refusal because he's been coerced? Is it totally voluntary? Let's say somebody who wants to really get a company or something. There are certain children like that. Wants to get the ownership of the company, should get the father to give consent for amputation, so that the company then belongs to you, because now the father can't run around and look after the company. So is it voluntary, the consent? So these are the steps. Identify the decision required and the information relevant to it. Then you need to assess the cognitive ability. That's whether the patient can listen to it, pay attention, understand the information, retain the information that is given, and also evaluate the pros and cons to reach a decision. And they should be able to communicate it back. So what are the possible causes that might impair the ability? It could be delirium because of confusion. It could be dementia because the patient has now lost the capacity to judge, capacity to retain information, capacity to estimate, and so on. So all of these are cognitive abilities: the judge, estimation, execute decisions, decision making, and so on. If you are learning disabled, another problem, because you might be 25, but your brain is only developed up to a level of 5-year-old. So again, they can't make the decision that can be usually made by a 25-year-old. So those are cognitive ability. But then, as in the case I mentioned earlier, where I say that I don't want to give consent to the amputation because the doctors are killing me, that's because of the psychiatric illness. So you need to check all of these when you're doing the capacity assessment. Usually, this should be done by the doctors in the ward, but we see more and more referrals are done to the psychiatry unit to do this assessment, particularly because of the step 3 and 4, to test the cognitive ability as well as to exclude a mental illness. So are there any questions that you want to ask up to that point before I move on to the psychiatric conditions part? Let me check the chat box. No, okay. So what are the psychiatric conditions that you see in the critical care? Delirium. It's a common medical emergency and associated with increased morbidity and mortality. And if you diagnose the initial condition, like the sepsis first, and then as the next step, if you diagnose the delirium early, then it leads to most favorable outcomes. So what is delirium? Acute global impairment of consciousness. Until yesterday, I was fine. And today, I am confused. I don't know where I am. I don't know who I am. I don't know what the time is. And I can't pay attention. And awareness is lost. I feel the environment as different. And my cognitive performance, the thinking abilities are less. So that's delirium, and it is directly secondary to the sepsis or the surgical or the medical or the obstetric problem that the patient is having. And there are types of delirium. Hyperactive, where the patient is very agitated, shouting and psychotic, usually when there is substance withdrawal or intoxication. This is the category that is important. Hypoactive. This is commonly misdiagnosed as depression. And they are silent. Usually, they won't even reach the ICU because they would be in the last cubicle. And this is dangerous because mainly hypoactive delirium is because of metabolic causes like hepatic encephalopathy, hypercapnia. So the patient is very blunt, very withdrawn. If you would only talk to the patient with great effort, that you would realize that the patient is confused, although not agitated. This person does not attract attention. Hyperactive ones, plenty of attention, first cubicle. Then there would be the mixed one. So sometimes agitated, sometimes stuporous, very quiet. That's the one. So if you can detect delirium, that's a major thing because that's a psychiatric sequel, a secondary to organic causes, which should be prevented. And then you need to be careful because in delirium also you develop abnormal thoughts like delusions, and also they develop hearing voices when nobody's around, perceptual disturbances like hallucinations. So you need to differentiate whether this is delirium, dementia, or psychosis. Psychosis is clear consciousness, no disorientation. So they are like only having a primary psychotic illness like schizophrenia. Dementia is where there is forgetfulness, cognitive impairment, and they might be having issues like psychotics. So they have overlapping clinical features you need to identify accurately because in delirium, you have to treat the cause. In dementia, you need to treat the dementia. Depending on the type of dementia and psychosis, you need to transfer the patient to a psychiatric unit and start antipsychotics. So there's prevention. Little things like constipation, pain, prolonged stay in the ICU can lead to, can lead to delirium. So therefore, preventing that. Good blood sugar control, avoiding polypharmacy. That's how you prevent delirium. And treating promptly the organic cause, underlying etiology. And then you can treat pharmacologically or non-pharmacologically. Pharmacological, if there is a risk to life or to the others, because I told you, you need to treat the cause. Non-pharmacological, adequately lit rooms, if possible, having one-to-one attention to the patient, and encouraging relatives to come and visit, and talking very clearly and in an adequate voice. That's the treatment. This is very important. Like, let's say patients might end up in critical care secondary to suicide, attempted suicide or deliberate self-harm, or patient who is in the ICU, let's say because of pancytopenia secondary to chemotherapy, and now is in sepsis, might attempt suicide because he or she does not see the point in living like this. So deliberate self-poisoning, parasuicidal, deliberate self-harm, that is intentional self-harm that did not lead to death. Whereas suicide is an act with a fatal outcome. So after a person commits suicide, that person is no longer there. So fatal outcome. And deliberately initiated and performed in the knowledge or expectation of the fatal outcome. So it all depends on whether I want to die and whether I know whether the method that I'm choosing is lethal enough to make me die. So let's say I might read somewhere that taking 10 tablets of paracetamol is enough to kill me. So I would go ahead and take it. But then we know that 10 is not enough. So that person might end up as deliberate self-harm because that person is surviving. But the risk is there. The risk is high because he wanted to die. So suicide is something that you do with the expectation of dying. Whereas deliberate self-harm is where you harm yourself, not really with the intention of dying. It might be as a cry for help. It might be as a impulsive act, as a manipulative act, the way to cure psychological pain. So that's deliberate self-harm. Having said that, there are various classification systems where, now let's say, in certain countries, attempted suicide is where the intention was there to die. But deliberate self-harm is harming yourself, not really wanting to die. But in certain classification systems, failed suicides also are considered as deliberate self-harm attempts. So don't get really carried away about it. You'll learn it when you come to final year and so on. But just know that there are these discrepancies in the terminology. So whenever there is a patient in critical care who is having suicidal ideas or it's following an attempt of suicide, things what happened before, during, and after is very important. If the person has planned the suicide, that means the suicide risk is high. If there is a mental illness, the patient was suffering from depression, suicide risk is high. If I have finished all my final acts, if I have done my will before committing the act, then that is very important because then that means there is high suicidal risk. As opposed to my boyfriend dumps me and I go and take 20 Panadol tablets, the risk is high because it was not planned in part of everybody and it was an impulsive act, not really planned. Just like that, doing in isolation when nobody's around, then the chances of you getting rescued are less. The method, if it was hanging, most likely the chances of that being successful is high. Steps against discovery, do you do it when nobody is around? That means the suicidal intent was high. And after getting survived, if I still say, I was rescued, then that means the suicidal intent is high. Right, so I have spoken to you briefly about suicide. Then another one. When a patient is violent, sometimes you see patients standing on the ICU bed, shouting, screaming, because they are violent. And they would take off the cannulas, try to take off the central lines. And let's say if a patient who is in the ICU after major surgery is having a relapse of schizophrenia, still that person would become violent, not because of delirium, not because of the organic cause, but because now the patient is not on medications for the psychiatric illness and the psychiatric illness has relapsed. So you can talk to the patient, try to find out what's happening. So de-escalation can be done. Then you can give a time out. If the patient is fit to be put into a psychiatric ward, you can put it into seclusion. It's really not really practical, although I have mentioned it in the ICU setting. But then putting into a corner, that might also work, not to marginalize, but just to calm down, because a psychiatric patient who is really suspicious might feel really bad when they're surrounded by people. You have to offer oral medications like antipsychotic, like olanzapine or haloperidol, if the patient is manageably irritable. But you might have to sometimes, if the patient is really disturbed, we can't give IV because it's difficult to put cannulas and give IV injections if a person is really aggressive. So you have to go for IM medications, intramuscular. And if the patient is being sedated or tranquilized, you need to monitor. So another very important and another critical thing that might happen in critical care is because of alcohol. I mentioned earlier that they might go into delirium tremens. That is because of alcohol withdrawal. So the patients might have alcohol dependence. Now, let's say a patient who's in the ICU with hepatic encephalopathy, and that might be because of liver failure due to alcohol dependence. Then, let's say a patient is having alcohol dependence, then the liver failure, medical problem is there, and the patient has gone into sepsis. So the comorbidity might be there. So the issue is now, let's say a person in the critical care has gone into alcohol withdrawal, then usually we only give chloride epoxide if the liver is intact. But then if a patient is having liver failure, then you can't give chloride epoxide because it's metabolized in the liver. You have to go for lorazepam. So because of the psychiatric condition that is there in the patient in critical care, your management will also be different. Precautions, like let's say people who are alcohol dependent have very low thiamine stores. So if the CBS is low and 25 and you want to give dextrose, you have to give thiamine first, IV. So these things are all very small things, but very important, because otherwise the patient will end up getting Korsakoff psychosis. What is opiates? What are opiates? Can someone tell me what opiates are? Opiates are heroin. So opiate withdrawal is not lethal, but opiate overdose is. So they can be unconscious, pinpoint pupils, respiratory depression. So that's something that is important in critical care. We see young people coming, and now the current trend is ICE, methamphetamine, and they come with strokes, epilepsy-like features, everything under the sun, myocardial infarctions because of methamphetamine. So these are the psychoactive substances that are available in Sri Lanka, and half-lives. I'm putting this because it's important to know the half-lives, because the urine dipsticks, which you do in the ICU setting or in the ward setting, will only be valid if the patient's last intake is within this time period. Otherwise, anyway, like let's say a patient who is on heroin, if you do it 2 days after admission, no point, it's going to be negative. So I spoke to you about neuroleptic malignant syndrome. That is because of exposure to dopamine antagonists, that is the antipsychotics. And there's rigidity, there is creatine kinase elevation, there's autonomic hyperactivity, there is fever, mental state alteration as in confusion, and the patient not only will have CPK elevation, AST/ALT elevated, WBC/DC elevated, and there would be fluctuations in the vital signs as well. The crucial information is the patient would have been on an antipsychotic. Now, whatever the reason is, directly or indirectly, this is very common, depression, anxiety. Depression is coming through the sadness, anxiety coming through the fearfulness. So in depression, you feel sad, does not have energy, don't want to do anything interesting, poor sleep, suicidal ideas, poor attention, concentration. That's what will happen. In anxiety, which we mean generalized anxiety disorder, this fearfulness. So they are always worrying, apprehensive, they have autonomic overactivity, and always having aches and pains because of muscle tension. So both, if you are to call it depression, should be there for more than 2 weeks to start antidepressant, because you get what is called adjustment disorder. So if you're in the ICU for a long time and you're feeling the stress of it, but you don't reach the severity levels of depression, that is called adjustment disorder. The difference is in adjustment disorder, you don't have to really treat, it's self-limiting. So if you do start in treatment, the first line is selective serotonin reuptake inhibitors. You need to check for interactions because it has interactions with other medications, monitor for side effects like nausea, vomiting, and kind of rare ones like hyponatremia. And it's very important that you control the depression and anxiety because it has a negative impact on the recovery. So if a patient is having psychiatric illness in the past, you need to know what the medications he's on and what medications are bad for his current condition. For example, we give something called lithium. And if the patient is having kidney impairment, you can't give lithium. So that's important to know. And depending on the issue, you can continue or discontinue. A patient who is having lithium toxicity, you need to discontinue lithium. A patient who is now having kidney failure, patient needs to be off lithium carbonate because lithium carbonate is contraindicated when there are renal pathologies. Something that we really forget about. There's grief. This person does not have to die for another person to have grief. They lose for the family members functionality, the father, although still in the ICU, the father who has lost his health. I am losing a healthy father. So that also can lead to grief. Anxiety. Matat mehema veda, will I get like this? And if this person dies, what will happen to me? Depression, adjustment. And I spoke to you about social and financial issues. And the team, they would be stressed, they might be having burnout, grief, post-traumatic stress disorder, then generally depression and anxiety as well. So those are the things that I wanted to discuss about with you in relation to the psychiatric aspects of critical care. So I spoke to you about the impact and how psychiatric conditions are associated, and just rushed through very briefly some of the psychiatric conditions that you would encounter at the critical care. And I spoke of capacity, which is important, and the impact on others. Any questions? No questions? Okay, then we can leave.
Thank you, madam.